All right, I think we're ready. Chad, are we live?
Yes, we're live streaming now.
Awesome. All right. Well, appreciate everybody taking time today to continue to get information as we deal with COVID-19. Very excited to have the group that we have of doctors and experts here. We wanted to continue to provide you with updates, and that's our goal today. And obviously deferring to medical professionals as we try to navigate these times. Just a few reminders to set some context, and then I'll go back to what was shared about just how to share questions and information. We've had 4 phases. Our reopening task force really helped to establish this criteria along with the community in regards to giving us feedback from a couple of surveys. We've been in phase 3 for some time as we continue to work against obviously and minimize the likelihood of spread and mitigate against as much spread as possible. Our campuses have been open with the exception of any individual school that has a case or situation where we can't contact trace in a timely enough manner and clean in a timely enough manner to ensure student safety and immediate return. In kind of looking at our numbers, you can see, and obviously Dr. Hendricks and Adams and Dr. Woods can speak to this along with Nurse Zalstra over the course of the evening. But you can kind of see what's happened with our cases over the last week or so, and kind of how things are trending. Obviously, very, very positive, very, very appreciative of obviously our county mayor and what's happened with the requirements for masks, and that has had an impact on behaviors across our community, I firmly believe. And so our students, I'll say, was in a couple schools today, and our students and teachers, and I'll spend a moment on teachers in particular, but our students as well have done just a phenomenal job in response to, really what is an unprecedented situation, extremely compliant with mask wearing and have adapted very well to it. And again, very appreciative of our teachers and our leaders, our staff members, just the way in which they're navigating this season. And again, we see how cases have moved. And kind of looking at the trends and what's happened, you see prior to the early part of the pandemic in May, as we were navigating and moving as a community. Obviously, at some point in July and late June, as testing increased, we kind of reached a high. School started around, or not around, on August the 12th. And then obviously, we're very pleased that, it does not appear that the start of school has caused increase within spread within the community. And so we've seen the numbers continue to decrease, which is a positive. We update, we have a live dashboard that's on our website that we update, try to say update on a daily basis. Any sites that are individually closed, we try to make sure that we update that. If that information comes in that night, we update it the following day to really make sure that the public is fully aware. We probably were one of the first systems in the country to really try to take this approach. We thought it was very important to openly report what's going on and who and where the impact lies. The state has given us some guidance and guidelines as we got closer to school. They provided some context and things for us to be thinking about in regards to low, moderate, and high spread within communities, and how to approach building closure, and how to approach case-by-case situation. And then the contact tracing, which in partnership with the health department is a very tedious task, how to approach each of those situations. So we're very appreciative of that support. As I've spoke to a little bit earlier, it is, we do know and firmly believe, we've even seen in some situations and instances where If anybody that wasn't a believer in masks, I'll tell you, being on this side with students being back in the building, masks have absolutely been critical to us remaining open. They really have helped to mitigate against the spread. And again, very, very proud of our students and our community at large and how we've responded to this. Just a couple quick notes here. We've obviously this is a point of interest for many parents as they have students that are involved in extracurriculars. We have continued with football, in particular volleyball and other fall sports. Have worked to reduce the number of fans that are in attendance to 30%. Tickets are pre-sold and schools have them available online. Masks are required at all games, and social distancing is encouraged, and trying to make sure that we do, again, those things that are normal for us in this season, that those things carry forward to the games and athletic events that take place across the county. Just very, very proud of the fact that our community at large has, we think, responded well to this safe pledge. Obviously, as we started school, it was a bit of an adjustment. I would say, as a parent myself, my son, I'll share, had a cough going on and a sore throat a few days ago, and we kept him at home for a couple of days, and actually went and got him tested and made sure that kept him out till we had the results of the test. And so we appreciate our parents that have continued to work with us. We think this has played a key role, again, in us being able to remain open. Also avoiding getting too close to others, face coverings and washing of hands. We appreciate the work that everybody's done collectively as a community. Spoke to the health department, and to Dr. Hendricks, and others can continue to speak to this throughout the course of the time that we have together today, but they've continued to offer free COVID testing at the Austin plant that's available Monday through Friday from 8 to 4, and then on Saturdays from 10 to 3. And no appointment needed. It's free, and encourage the community to access that. And then in regards to next steps, before we open up for just questioning and conversation here, we'll continue to revise our continuous learning plan as we, as doctors and experts, learn more, and we learn more, and we understand better how to respond. Our continuous learning plan is an evolving document, and to make sure you understand, we had developed a reopening plan. The state, a few weeks later, said every district had to have a continuous learning plan. We were positioned really well because our reopening plan addressed most of the areas in the continuous learning plan, but the continuous learning plan is an expectation of the state. And so we will continue to make sure that that plan evolves and reflects what we learn in regards to COVID-19. And so we really, again, are very, very grateful to have this esteemed panel of guests with us today to answer the medical questions that we know so many may have as we continue to navigate COVID-19. We have Dr. Adams from Erlanger Health Systems. Appreciate Dr. Adams being here. Dr. Hendricks from the Health Department, Dr. Woods from Erlanger, and Nurse Margaret Zalstra from the Hamilton County Health Department. Appreciate all of you taking time and being in attendance today. So Jenny, you might want to remind everybody just on kind of the cadence of what will take place and happen, and then we'll open up the floor for you to ask questions to these esteemed medical professionals.
Thank you. So the way that this will work, since we've got a larger group, is that you'll put your questions in the chat box and send them to me. You'll see a couple of people that you can send them to, but send them to Jenny Pickard, and I will read the questions to our panelists today. So the first question, and we've received this question a lot, especially over email ahead of this meeting, is about the active case numbers and how there's been some big fluctuation in those over the last couple of weeks, and there's been changes to the criteria. So Dr. Hendricks, if you could just talk about those changes, that would be great.
Certainly. An active case is an infected person is still contagious, basically, people who are still actively in their course of disease. This is determining that exactly. As a general rule, we know that when people get infected, after about 10 days, their chances of continuing to be contagious falls off to almost zero. So we generally kind of consider that the period of contagiousness. As things have developed, one of the frustrating things about the disease is brand new, and we've been learning things all along. For a long time, the CDC and the state were keeping people on the active case list for 21 days, which was kind of an excess of caution. Because the science has gotten better and we've gotten a better feel for that, they moved that to 14 days, which is a few days more than the 10, but that is to allow for those occasional patients that might still be sick, still be having symptoms. If you're still having symptoms, the 10 days, then, you know, we still consider you contagious, but the 10 days is the guideline if you are asymptomatic. So this was kind of an automatic roll off in the data. We're trying to track these people. We're trying to find out when they're that they're asymptomatic after 10 days and then release them from isolation. But these people are all, we've got across the state, thousands of people like this. So the computer programs were kind of automated such that everyone would roll off initially after 21 days, and that would adjust automatically. That was changed recently to 14 days. And we recently had a little glitch within our health department where apparently the computer was not automatically rolling those people off. And we didn't realize that. And we started looking and realizing that those numbers, actually someone had out in the public had kind of pointed out to me, these numbers seem kind of high, and we got looking at it, and our epidemiology people went to looking at it and realized there was, they really were going to have to do a manual data adjustment on this to allow this to happen. And I'm sorry, I'm not technical enough on the program and all to explain it better than that, but it was basically a programming glitch that there was a workaround for. We fixed that. That's why one day about a week ago or last week, we suddenly had this huge change from 1,600 active cases to we're running about in the 600s now. So that the new number is the active number. We were retaining people in the active list for longer than they should have been. We've got that fixed. We should be able to keep up with that. We're very sorry for the confusion over that, but we feel like the numbers now are more accurate and better reflect how many people are out there who are still contagious. Technology is a wonderful thing, but sometimes when we rely on it too much, it's better to go back to the good old fashioned manual way of keeping track of things. So.
All right, our next question is, if active cases are theoretically in isolation, why do we use that as gating criteria instead of the rate of spread per 100,000, which has consistently placed Hamilton County in orange for accelerated speed, even with the new definition for active?
I might need to hear that again. Why do we report people as per 100,000 as opposed to the total number?
It's why are we using our current gating criteria instead of the rate of spread per 100,000?
This is the Harvard study criteria. People want to know, why aren't we using the 10 per 100,000 Harvard study criteria?
The Department of Education will have to, they decided on the Harvard criteria. The per 100,000 just allows us to compare ourselves, make it a apples and apples comparison to other counties around the country, to account for population. So that's useful comparing yourself to other counties. But I'll defer to Ms. Towns or someone for the decision.
Well, no, I'm sorry. Let me clarify. The 10 per 100,000 it's actually criteria. So Harvard has said that if your daily rate of increase is more than 10 per 100,000, they consider you not in a position to reopen schools. Then their next gate is like, I think it's 25 per 100,000 is what they consider like the most severe case of community spread. So I think people want to know why that study set essentially gating criteria of 3 levels that were based on the number of new daily cases by 100,000. So the cuts are like 10 and 15 and then 25 or something like that. It's the Harvard metric system is what I call it. But it's actually based on new daily cases.
Okay, I'm not, again, maybe I'm still not clear on the question, but I'm sorry, you might need to read it again, or maybe I'm not understanding what their question is. I know those are the criteria being used. Someone else, Charles or Stephen?
Read the question one more time. I think I might have a thought on it, but just read it one more time.
So the question is asking, since active cases are theoretically in isolation, why are we using active cases as our gating criteria instead of using that spread per 100,000 number that Nakia was referring to that the Harvard study uses?
So I guess I'll say I'm not sure exactly, first off, all these criteria are best estimates. And I guess what I would say without the practical answer is, I think you pick something and look at it and follow it consistently. If you have a rising new case rate, which also will be reflected in your active case rate, the active case rate will include those. It may be a little bit more stable measure, less subject to daily change as new information comes in and out. So it might be a little bit better measure, but they're going to closely mirror each other within a few days, I think. And the other good news in this is that you can see from the trends that we are trending down overall. And I think whatever gating criteria we have, we're certainly, what we're doing, at least I think, seems to be working with the overall trends going down, with the magnitude of reopening of schools and activities. We're not seeing an uptick overall in our community right now, at least the way I'm seeing the data. Dr. Hendricks, correct me if I'm wrong on that. But so I think it's a great question. It's got technical parts to it, but I think the practicality is it's probably good to look at both. And I think we're not looking at isolation, maybe the gating criteria based on one of them. But again, the view has always been that we would look at multiple of the criteria. And I think right now there's a lot of good news on the community trends. And Dr. Hendricks, is that a fair assessment of it?
Yeah, absolutely. And the very first part of the question about, why do we use active cases if they're in isolation? Hopefully they're in isolation, but we anticipate they will be. But the number is a reflection of how much disease is in the community. So obviously, if you have a higher number of active cases, that indicates you've got more disease in the community. And the lower the number, then the lower the incidence of disease in the community. So like Dr. Woods was saying, to me, the trends are, what I really like to pay attention to. If you've got number X, but yesterday or last week you had number X minus 20 and you're going up, then to me, that's more worrisome than if you're at the same number X and yesterday you were at X plus 20 and now you're going down. And so I really like to look at trends, but on a day-to-day basis, you've got to have something to compare. So I think that's the broad thing there, but it's a reflect, even if they're in isolation, it's a reflection of how much illness is in the community.
Yes, and I guess
I think that the bottom line question for us is, should we today change our strategy in a situation where the number of cases are going down fairly consistently? And I would say, no, not at this time. But if things change, then we rapidly need to rethink it. This is an experiment. Unfortunately, nobody knows the exact answer to it. And I guarantee you by the time it's over, we will have some changes in strategy. We just don't know what the right answer is today.
Right,
yeah, I agree. I agree with that.
Yes, and I would say, and that's why we want to watch all of this. So it's a very good question. So don't read into any of these responses from any of us that we think it's not a great question. It is a great question. And I think remember also that what we're seeing in our test results is some degree of an undercount of what's out there. But when nothing's really changing in terms of our availability of testing, I think that's been pretty stable in the last number of weeks. So the trends we're seeing in hospitalization cases, the trends we're seeing in total new cases that are recognized, I think is a real downward trend, which is encouraging.
All right, our next question is about when a school building is being cleaned. What does that mean when we say that we're cleaning a school building after there's been a positive case in the building?
Absolutely. I don't think Dr. Robertson is on here. So essentially, it is a hydrostatic mist where our third party SMS will come in and apply hydrostatic misting to the areas across the buildings. And so it's much like the strategy that we would have used in the past for particular buildings that may have had increases in the flu or some type of area. It's an accelerated way for us to disinfect those areas via the mist.
All right, our next question is, are gaiters or bandanas okay for face covering?
I think the focus for us for face coverings is more on the layers and the snugness. And I have to say, looking at the CDC's website, as they're right now saying they really can't vouch for gaiters just because they're still researching it. Their formal advice is still sort of, we can't vouch for them right now because they're still studying them. Most of the evidence that I've seen, and certainly the CDC advice and what you see, is that the number of layers is one of the more important things, plus a nice snug fit. I get a little anxious about the bandanas, and I can't, this is probably more my personal opinion, frankly, than anything, but because a lot of times, you know, it's a single layer and it's hanging kind of loose, and you really want it snug around. I'll show you. Here you go. I got mine handy. It's nice and snug around, and it's elastic. So the layers, the snugness of it, and making sure it covers your mouth and nose are the important things right now. I think the word is still out on, you know, gaiters versus bandanas exactly, but I'd focus more on the layers. And
yeah, Duke University researchers, and it's ironic that I saw it come out today, published a study looking at the effectiveness of various mask types. And N95 mask is, of course, the best, but multi-layer regular mask or surgical mask are pretty close, and then bandanas and gaiters were not very effective at all. So I would encourage people to stick with a regular mask, particularly one, as Dr. Hendricks has described, is tight-fitting and multi-layered.
All right, our next question is about athletics, and this will be two-part for the medical team, and then Dr. Johnson, if you could also add to this. Number one is it safe for our students and staff to be participating in athletics and other extracurriculars? And then Dr. Johnson, if you could just remind everyone the procedures that we are asking people to follow at our athletic events, that would be just a great time to mention that.
Well, I think we are still understanding this. Of course, if you can live your life in an entire bubble, quarantined for weeks before, we're all competitors, or have essentially been quarantined and are around people who've been quarantined, or only around others who have not been out and about, sort of like the pro basketball teams have done. You can say absolutely your risk of getting the COVID is essentially zero, as it seems to have played out. In real life, in schools, it's maybe not in our lives. We can't maybe be that sure that there's no COVID around. However, so far there seems to be the procedures that are working seem to be going pretty well based on the numbers. Would be my thoughts right now. And so that is a relative safety that you balance out against the, their risks of not having these programs and activities that you can factor in as well. So I'm seeing, I think, encouraging results from what is being done now. The approach that's being taken as being relatively safe, about as safe as we possibly can make it. That doesn't mean there may not be someone who's asymptomatic, doesn't know they have it, and exposes someone else, and there's another case that shows up. But I think there are measures in place to try to track that down and keep that to a minimum. And again, with the idea that most of the children, and teenagers are going to have relatively mild infections overall. Again, as we've said before, usually they're mild cases. Occasionally there's an exception. I think the risks of something serious are really low. Just we can never get some of these risks to absolute zero. Other thoughts on that from Dr. Adams or Dr. Hendricks?
Yeah, I agree, and I think it depends on the sport. So I have no qualms at all with my son participating in cross country. I've got some real concerns about his desire to do the wrestling season, regardless of what the TSSAA says. So I think it depends on the sport. And it's a risk-benefit analysis, but I think the school system's done a good job in protecting people. I have a family member who caught COVID participating in a sporting event, but it wasn't the sporting event that got him. It was hanging out with his buddies all grouped up afterwards, and one of them was coughing and sneezing with COVID. So I think the before and after parts are as important or more important than the actual sporting event.
And I will say right now, again, this is one of those times where we all have to be honest and say, gosh, is there a runny nose? Is there a sore throat? Those may be due to something other than COVID. But if we can't know that or can't have rapid testing, then the rule has to be or should be, you don't go and play. You sit it out so you don't expose someone else to whatever that may be. And that's hard. It's a hard decision to make at times. But I think that's the best rule. If we are fortunate and continue to see downward trends in the community overall in transmission as people continue to wear masks and work at socially distancing, that will further decrease risks. Obviously, if we see an uptick start, that will change the risk equation, I think, for everybody. And so that's where we have to watch these trends. Right now, we are seeing encouraging results, but it's no time to get complacent with the plans we have in place.
Yeah, of course, the health department, we try very hard to use CDC guidelines because we know they're generally well studied, and they rank order sports in a series of 5 different risk categories from, outdoors, cross country is much lower risk, like Dr. Adams said, and then contact sports, the more contact, the higher risk, and indoor sports obviously are higher risk because they're more contained. So it's very difficult, and I'm going to ask Margaret to comment here in a second, but it gets very difficult to determine how much risk. There was a study, one of the local docs who's very active in this sent me about volleyball and showing how little spread there is among, soccer players, I believe it was. But at the same time, we see professional sports teams, local sports teams with clusters in them. I think I read today, the Titans have been knocked out of some games because of a cluster. So, and like Dr. Adams said, sometimes I think the problem is more what happens after the game or on the sideline than what's actually happening in the field. But we have to take that into account when we know that we see clusters in sports teams, and we know that, you play the game, you get in the bus, you go out to dinner, you have a party Saturday night. All those things have to be taken into account. And Margaret, I want to bring Margaret in because she helps actually interview and talk to these people and see what she's hearing.
So yes, we've been involved with lots of sports teams that we have had to, put into quarantine, and, we never want to do that, but we hear about, their social events within that sports group, or we hear about, they huddled in the locker room before the game or at halftime or something, and that's probably contributes to the most risk. It's not the sport itself necessarily, although some sports are going to be more risk, but it's all the other stuff that happens during those kinds of events. And sports teams tend to be very social groups, so they're going to want to get together and hang out.
Yeah, and this is where it's so important for parents and coaches and teachers to remind these, these kids that the precautions, they can follow the precautions perfectly at school. And if they, go home and, have a party or get together with their friends and everything, it's all out the door. So it's, the same rules apply everywhere. So that's the kind of thing we have to look for.
And then Dr. Johnson, will you just remind people what our procedures
Yeah.
are for athletics?
So yeah, so a couple things I'll speak to. One is just kind of some protocols we put in place. For sure earlier, we're reducing the capacity of stadiums and facilities to 30%, pre-selling tickets. Everybody must wear a mask several times throughout the course of the events. We're reminding the public about the expectation to wear a mask. And so several steps like that continue to be in play. We don't have concession stands open. I mean, there are a multitude of things that aren't coming into play. I think it's really important to miss this conversation. I think maybe Dr. Adams had spoke to it. It's a risk reward conversation. That I think parents and we as a school system have to have. We are responsible obviously for the safety of children, but also the academic development of children. And I firmly believe that it's not just what happens in the classroom, but it's those out of classroom experiences as well that help to develop a whole child. And so for some students, it's STEM. We're literally, when we return from fall break, we're having very deep conversation right now about, what does robotics, what does it look like for robotics teams? How do we, begin to, allow our students to do things in a thoughtful way? And obviously we're going to be taking medical expertise and advisement around those topics. But, there is a whole child mental health component in this season that is really important and really valuable. And we know that sports and athletics do play a key role in that as well. And obviously TSSAA guidance, the governor came out and spoke, hey, Tennessee's going to play football. And the TSSAA came out with guidance. The National Foundation of High School Athletics came out with some guidance. And very, very proud of our schools overall and the way in which they've approached, this difficult situation. One of the things Dr. Hendricks said, and I will say this as a former student athlete myself, long ago, is the propensity, and I think Nurse Alster said this as well, the propensity of student athletes to desire to gather before and after, in particular after. Really it's where teams and schools and programs have to be very, very thoughtful about what's happening after ball games. I know it's very difficult to go straight home, but the more you can go straight home, the more likely you're going to be to probably be able to compete that very next week. And I was reading an article maybe earlier today on Notre Dame. The football program had a bit of an outbreak, and they went back and traced it to a team meal that they had done, a pregame meal that they had done. And they're going to redo how they do pregame meals. And so all those things are things that, Brad Jackson and Justin Robertson, our team, continue to work with schools on. And we continue to encourage the public, if you are in that 30% that gets one of those pre-sold tickets, you must wear your mask. And we ask that you comply with those things. And, our goal is for our students who also compete in extracurriculars or participate in extracurriculars, to have as many of those experiences as practical during a very, very difficult time for, everybody. So we're proud of what's happened so far, but there continues to have to be attention to making sure we do the right thing. The last thing I'll say, and I'll shut up on this topic, but it hit me today, and I sent our Chief Operating Officer an email for a reminder for our district athletic director that we'll be meeting with ADs in the next day or two, is a lot of times when things begin to kind of settle and we've had some settling where, you know, we've been able to have some athletic events, and, you know, the numbers are you know, I won't say they're great, but they're, you know, we see things kind of settling out. People begin to become more lax, and it's not a time to become more lax. As been said earlier, it's a time to become even more intentional, if we're going to be able to continue to do some of what we've been able to do to this point. So
You can't let down in the fourth quarter, can you? One of the comment, people think we're picking on sports, you know, but singing has known to spread, you know, droplets, and we see outbreaks in choruses and choirs. So, you know, you know, I was a chorus person myself. I mean, I love to sing. So it's not just athletics. You know, there's a lot of different situations that we have to be careful of.
All right, our next question is there evidence that the mask mandate is working?
Well, I have to say yes, and I think Dr. Woods addressed this earlier. We are seeing cases go down, positivity rate go down. Had a little bump in hospitalizations the last couple of days, but over the last few months, we've seen those numbers drifting down. So I think that, yes, it does seem to be working. I think that just the kind of anecdotal evidence is that people are complying. We hear a lot of people calling in and saying, I was at this establishment and people weren't wearing masks. And we look into it, and usually we call, and the vast majority of places like that have said, oh, you know, yeah, we'll work harder. So it's working partially because, you know, we put that into place and gave a little extra incentive for people to wear them, and partially because people are complying to a great degree, not 100%, you know, but I've been very gratified at the response that we've had and the results.
I mean, I agree. You know, we have people out and about going. I'm going into stores and different places, and I think the vast majority of people have been wearing masks. Do we like it? No, but we're doing it, and so I think that's good. This is a, you know, if you want to call it an experiment that we're all participating in together, I would say the numbers going down is a good test of the experiment, that it is indeed working. We also, there's a great study of I think from June or early July, when they just reopened hair salons in Missouri. There were 2 hairdressers that both were symptomatic of COVID and treated 139 clients over a couple of days or so when they were symptomatic. They were in masks, and all of their clients were in masks, and none of the clients got COVID from it. And had that not been the case, probably many of them would have, given the close proximity. So are they perfect? Are they 100%? Probably not. There's probably a small amount of aerosol spread that could get through, but they're pretty effective, I think, is the ultimate answer, and especially when we're all doing it together as much as possible, realizing there will be some breakdowns. And yes, I have gotten out of my car and been halfway to a store and realized I didn't have my mask on. I had to walk back to my car and get it. So it's hard.
You know, I happen to have been looking at the South Carolina Department of Health website today, and they actually have a section on there where they compare the counties that have put in place mask mandates versus those that haven't, and there's a clear difference in the case rates there between that. And I've also seen a curve from Kansas that showed a clear difference between the counties that have enacted mandates and those that haven't. And I've actually asked the state if we could, Tennessee, if we could generate, you know, some of those comparison numbers too, and see if that's the case here, because I believe it will be consistent.
Right, and the last thing on this, if you look at a lot of the states that had spiking cases back June, July, when we were worried at that point, and then we had mask mandates and things started going down. And in a lot of the country, the Midwest especially, we're not seeing cases. And you know, when you're not seeing cases, when you don't know anyone who's died of this, I know 2, including my father, that you know, you tend not to take it seriously. And it's hard and I get that. If you're not seeing it, it's invisible. Why all this fuss? But they're starting to see a lot of cases in the Midwest now. They're on an uptick, and they've not been as rigorous in terms of mask wearing. And I think they will start that now, and we are seeing the results of that.
All right, our next question is, since school has been in for a month and a half, are the cases that we're seeing in school majority coming from transmission within the school, or are they coming from outside of the school environment?
Margaret, do you have a feel for that?
I would say that from my intuition, I haven't studied this clearly, and this would be a good data piece to look at, that certainly cases that come into school are typically from contact outside of school, either in their household or elsewhere. But we are seeing transmission within schools, and you know, it's hard to pinpoint why that happens and when that happens. I think the high schools have more of an issue with that because of the significant social interactions that either happen outside of classrooms or outside of school completely. So, you know, we're definitely seeing transmission within that age group, which makes sense. They're more social beings. But I do have a little bit of a concern that I wanted to bring to the school system. And so we're seeing a downward trend in our community in general, but I was looking at, since we went back to, you know, phase 3, that we really haven't seen a downward trend in the number of cases overall in schools. It seems to be staying pretty steady. It's consistently between teachers and students, active cases in the mid-30s. And I just wondered if the school system was kind of looking at, you know, what is the trend in the school system, rather than looking at, okay, in the community, it seems to be decreasing. But we're not seeing that overall in the school system, in school cases. And we're just looking at public schools where we can see that. In private schools, you know, we have a large number of cases as well.
Yeah, I was going to say, and I think, I don't know if Jim Bronson is on the line, but we actually have been monitoring what we consider Epilink cases. So, right, we of course are contributing to the contact tracing process, that we know for student cases which children interacted with each other in their classes, as well as which teachers they interacted with. So when we ask students who are close contacts of confirmed cases to quarantine, we've now also started flagging, then does one of those close contacts become a positive case, right? So is it an Epilink case? And we do that both ways, right? Like, some people get caught up on, well, which came first, the chicken or the egg? If we have 2 Epilink cases, it really doesn't matter to us who got tested first. We know that they crossed paths first, so we don't actually know who was infected first, but we count that broadly. So I would say, when we were looking at this data, thus far, we've had about, you know, one school being the outlier, to your point, a high school. But across the district, we have not been able to find, I would say, you know, of the total number of cases that we've had, it's somewhere between a half dozen and a dozen Epilink cases that we believe that they may have come in contact with each other. Now, I will tell you that even in those situations, we then have had, you know, students who and staff who were in contact with each other, but then we get the information that somebody in the family had COVID. And so there again, we don't know which came first, the chicken or the egg. Did somebody bring it from their household outside of school into the school system? So we are, you know, looking at that. We don't see, in fact, we feel pretty gratified by the fact that we have not had many scenarios where, when we put a group of students in quarantine, having been confirmed close contacts, that we then see multiple additional students getting positive results for COVID, right? So I think that helps us say that we feel pretty good about our mitigation strategies, right? All the things that we're doing, masking, hand washing, social distancing, all of those things. I think your point around our cases going down in the schools, I think we think about this a few ways. From our perspective, we want to look at our quote unquote, if you will, percentage of cases versus our school population. We look at whether or not that is very different than the county. And so we've been a little bit lower than the county in terms of a percentage basis from the beginning. So now it may be that county community spread and think about the active cases numbers, right? But we feel like they're in line. So we haven't been very concerned, I think, from our perspective, because as you said, we have so little control of outside the school building that our view has been that we need to control spread within our buildings. We measure that between, do we see many Epilink cases coming from the close contacts that we make, that we identify rather, and whether or not we would definitely be alarmed if cases were going up. And so I think that from our perspective, steady is the new normal, right? And we've identified that in the school district, it's about 1 to 2 new cases a day between staff or students in our school district. And that has been over the course of the school year. And so we would just consider that, of course, we think some of it too is that obviously we encourage people to test, because we have guidance that says for our employees, you're going to get tested if you're presenting with symptoms through our nurse hotline. And then for parents, we also have guidance with our safe pledge that you can't come back to school without a test. So when I think one of the doctors mentioned that undercounting, we do feel like we have a pretty good, there's not a lot of undercounting. I think that what's happening is that we're getting people to test in our school district because they have to access our in-person learning.
I think it's important to realize too that this is a national trend. We're seeing increases in the teenage, and we look at 10 to 20, 10 to 19 or whatever, but I think we're probably looking at the teenage and in the 20s, college age. That's where we're seeing a lot of the increase nationally. So that's not unique to Hamilton County. And I also think we have to realize that the virus does not appear de novo in a school. I mean, someone brings it there. Our goal, your goal, is to keep it from spreading inside the school. And part of our goal as health department, and everybody's individual goal, is then keep it from spreading outside the school. Because just like Margaret said and everybody else has said, we know kids are social, and the older kids are particularly social, and it's tough. It's tough. But just continuing to do all we can is appreciated.
All right, our next question is about testing. It says that getting tested is still inconvenient. Is there a plan or discussion of setting up more health department free test sites?
I don't know what you know, Margaret. I think we're, it's just a function of staff and resources. We're running a free testing site 7 days a week. I think that we're going to be changing our hours a little bit, maybe in a couple of days. I think maybe October 1st to 8:30 to 1 at the Alstom site. There are a lot of private practices that are doing the testing and urgent cares and things. And I don't know of any plans to open another health department site off the top of my head. Have you heard of any talk of that?
I have not either.
Now, I don't know, Dr. Woods, Dr. Adams, have y'all heard of any other? Of course, SIMPA does occasional pop-up testing, and Clinica Medicus is still doing a lot of testing. But
just to give a little perspective, though, it is inconvenient, but it's inconvenient to get a strep test, and nobody argued with that last year. If you had a sore throat, you get a strep test. So when we did our last session, the wait time on a test was about 7 days and could be longer. There were people that were waiting 10 days on getting the results back, which at that point, you either got better or you're in the hospital at that point. Now we're down to turnaround times of less than 24 hours typically. There's increased availability of rapid testing. So if you give it another month or so, probably most healthcare facilities will be able to turn around a COVID test in the same time it takes to turn around a flu test. So we've made real headway, and it makes decision making much easier. So, you know, the last session we did, you'd have to think long and hard. What do you do with people that have, you know, a cough? Is it pollen or not? Well, they're going to be in isolation for days before you even know. So it's still not optimal. You know, I'd love to be in a position where we could say every school nurse gets a test kit, but that's probably not going to happen. But it is much better than where things were even a month ago.
Right, our next question is for the health department, and it says, what are your thoughts on not testing someone who has been exposed to COVID unless they have 2 symptoms?
I think, and you know, I realize the CDC kind of changed its guidance a little bit here and there, but they're back to recommending that people who are exposed should be tested. If you have a you know, close contact with someone with COVID, you really should get a test, because we know that there's a large percentage of people who will be asymptomatic. And even though a negative test does not get you out of quarantine, because the whole point of quarantine is we know it can take up to 14 days to, you know, become positive. So if on day 5 you're negative, that doesn't mean on day 6 you're not going to be. So that's the hard part for people to accept, that, well, I tested negative, why am I still in quarantine? Because, you know, you still could test positive. But I do think it is important to test people who've been exposed, because if they do have the virus, the approach to their isolation all changes, and it just makes them a little more aware of watching for symptoms and that sort of thing. So I would strongly advise that. And how long to wait? We know probably half people at least are going to be positive by around 4 to 5 days. So I think at least 5 days is a good number. I think the state is saying 5 to 8 days. And so I don't know if Dr. Adams or Dr. Woods has any opinion on how long to wait. You don't want to do too early, because it does take at least a few days, at least 2 or 3 days, but 5 days seems to me like a good number.
I agree. If I had to pick a number, I would say 5. And I think you summed it up well. You know, we have learned a lot about this virus in the last 7 months or so, or 8. But we're still learning. And there's certain things like this where, you know, the testing is imperfect, but the alternative may be worse. And so I do think this may have some value to do. Although I can understand why you might say, well, why do I go now if it doesn't tell me I'm not? It doesn't rule it out if I'm negative today. But for those who are, it may be helpful. And then certainly just it may heighten awareness of people just to keep paying attention to how they're feeling. If they got tested, they're negative, but they start feeling bad 2 or 3 days later, okay, get tested again.
Yeah. And anytime you have symptoms in quarantine, you should get tested, even if you had a negative test the day before. That's a good point.
Right. Our next question is, do the medical professionals think cold and flu season could be less because of the COVID preventative measures?
I actually think that the answer to that could be yes. Now, I don't want to, so I'm relatively optimistic that we might dodge a severe flu season because of masks, and hopefully also because of flu shots, by the way. And we know from Southern Hemisphere countries where typically this is, you know, they're coming out or during their winters when you would have expected to see a lot more flu, they didn't see as much when they're in areas where masks were being worn. So we know that flu is transmitted by droplet transmission, which masks are very good at preventing. So it's possible we will get through this with less of a flu season if we continue to use masks, and may not have the double whammy people have been worried about. I'm not willing to certainly take that off the table yet. And again, don't want us to be complacent, but we might get a 2-for-1 for this. In the Children's Hospital, we are seeing a few children come in with respiratory viruses right now that are not COVID and are not flu, but are rhinoviruses and other related viruses, so another family. So there are things being transmitted out there, and perhaps due to masks not being worn as much at home and things like that. We may still see some flu, just like we're still seeing some COVID, but hopefully it will keep it all at a minimum. So like everything else, we'll wait and see.
Get your flu shot.
All right, so we only have time for one more question, and the question is about vaccines, and it's what is a reasonable timeline for a vaccine?
Well,
So that's a hard question. I can tell you that there are dozens of companies that would all like to be the $100 billion lottery winner and come up with the winner. Johnson & Johnson has what appears to be a highly effective vaccine that where 98% of people developed antibodies to the virus, and they announced today, I believe, that they're doing a 60,000 dose trial looking at effectiveness and whether or not there's side effects. So, and they have said that they could be in production by the first of the year if this turns out positive. So there's multiple other companies doing the same thing. I believe the CDC has said that we might see one released this calendar year, but if not, early in the next.
No,
you guys heard any different?
No, I think that's right. I am, again, hopeful we're going to have 3 or 4, possibly, maybe, and over time, maybe even more different vaccines. Some of them are 1-dose vaccines, some are 2-dose vaccines, and obviously one would be better. I think the Johnson & Johnson may be the 1-dose vaccine.
That's my
But
understanding.
the reason that we study them in such large numbers is just to be sure they're safe, because we want to make sure there aren't rare side effects like 1 in 10,000 people where something really serious happens. And if we study all of them that way, we can certainly have the safest ones that are also effective from these studies. So go ahead.
I was going to say one smart thing that's being done, it's probably an expensive thing, but is they're going ahead with manufacturing. Usually you wait until you find out if it's effective, then you start manufacturing it. But they're going ahead and working on manufacturing large doses of these various vaccines so that once one of them or more of them become approved and they're shown to be effective and safe, you won't have the lag time of then manufacturing. The early doses they're going to have to stratify it a little bit, prioritize, probably a better word, and will likely go to like first responders, frontline medical workers, those kinds of people. So for the general public, it may be, pushing further into 2021, but I agree with Dr. Adams. I would not be surprised to see a vaccine rolling out by the end of the year or early next year. That's just my opinion based on public information and,
Yeah, and one other point on that, we're not going to return back to normal as it was before until an effective vaccine has been distributed through most of the population. So if it gets released on January 2nd, it doesn't mean January 15th we throw a mask in the garbage and throw a big party. That's not going to happen. But I do want to leave everybody with positive news, which is the use of masks have really changed the trajectory of Chattanooga. If you look at where we were in July, our numbers were climbing just like some of those other locations that had gigantic outbreaks. And every day I watch the number of patients in our hospital, and particularly the ones on ventilators. And I looked the other day and I looked at the report and I couldn't believe it. We had 1 patient on a ventilator from COVID-19. And if you think, well, okay, well, that's 1 patient, but a couple weeks ago they were trying to shuffle around You know, we've got an entire intensive care unit that's only COVID patients on the ventilator. Where are we going to put the other ones? So it's not something the public sees, but if that bit of empowerment that the efforts are working, the efforts are holding it down, that can be a positive for people, because I think that there is a degree of hopelessness if you feel like you can't change your situation. And the evidence is that we can change the incidence of COVID in our community and how many people get sick, and we just have to hold on long enough for a vaccine to come out and be widely distributed.
Yeah, and I want to give a plug to my colleagues in the front lines too. Obviously, you prefer to prevent people from getting sick, but I think that the intensive care and emergency and just the people who are out there, you know, manning things in the front line have learned an awful lot in a very short time about how to manage this disease, which is it's a different disease. It's you know, it's fascinating from a pathophysiologic point of view, and fascinating in medicine is usually not a good thing for the patients. But in all seriousness, the learning curve for the frontline docs treating people in the hospital has been amazing. And I've talked to them, and they've learned so much and have gotten so much better at treating it that that's contributed a lot too. So, you know, I'm just impressed with my colleagues.
If you look at what was happening in Italy in the spring, or in New York, where most people that went on a ventilator died, it was really horrific. You want to talk about depressing for the medical community? You say, well, 85% of your patients are going to die if they go on a ventilator. We are not seeing those kind of statistics here or in other places in the United States. The pulmonary critical care teams have treatments even as simple as steroids that are making a difference, and they're not seeing those kind of death rates. People are going on the ventilator, and most of them are going home. Doesn't mean all of them, but it's not what could have happened. So is it good? No, but there is light at the end of the tunnel, and it's not a train.
Can I say something from a epi standpoint? You know, we established a school team to respond to these cases in the school system, and you know, we scrambled to put that together, but we have an awesome working relationship with the school system in responding. And, you know, I think we're doing a great job in the amount of work that you all have in doing this, and that we have. And I hope that good teamwork continues. And
I second that. And I want to congratulate Dr. Johnson also on his recent accolade. But yeah, I think that the work I think we've done working well together. By the way, I'm sorry.
I know we're rolling along. We'd be remiss and first off to thank you all for continuing to take time to keep our community updated, to help inform us, and always being readily available above and beyond. We're so sincerely grateful. There have been so many folks that have been on our team on the ground with COVID-19 response, from Dr. Towns to members of our senior leadership team. But I will tell you that Jen Bronson, who's really been our district lead, has been absolutely phenomenal and in working with the health department. And about 2 weeks ago, I'll just share this. I guess about a week ago, she because she's working on the weekend, she was training up some of our senior leadership team on stepping in to support on Saturdays and Sundays. And about 15 minutes into the training, like I was overwhelmed. And so every week, every day, she's been doing that, and we're grateful to have her and so many others across our district, our school leaders that end up responding to the situations. I see some of them on the line, have been absolutely remarkable in helping us track down close contacts and really trying to work to mitigate. And so again, thank you all for taking time. I don't know, Jenny, is there anything else? I guess people can continue to send questions in. If they have them, we'll continue to take them. And But please refer to our district website. It's got our kind of standing information up there. And again, we look forward to seeing students in school tomorrow, and have a great evening.
Yeah, and Jenny, if there are additional questions and you want to forward them along, I'll be happy to take a look at them, and
Thank you.
maybe we can divvy them up between Charles and Stephen and I or something, but we'll do our best to respond.
Thank you all.
Thank you. Bye.
Y'all have a good evening.